Hi, I'm Dr. Jeff Lawrence. I'm an orthopedic surgeon for Gundersen Lutheran here at the Viroqua Center for Orthopedic Surgery. The great thing about hip replacement these days is that it tends to be relatively predictable and reproducible for most patients. Outcome studies show excellent patient overall satisfaction, and I'd be very optimistic that we can improve your quality of life with a hip replacement. We use a spinal anesthesia for most patients and numb things from the waist down. You'll have an IV in your arm, and we can make you as sleepy as you want to be. If you would like, we can keep you awake, and you can watch the procedure on a large high-definition TV monitor that we can put right in front of you. You can ask me questions. We can discuss the procedure while I'm operating. People that watch find it pretty fascinating, but there are certainly those that say, "No way, just put me to sleep." I do the same operation either way, and we can certainly do just that if that's your preference. I make an incision that extends across the butt cheek. Most of the time, we use a minimally invasive incision that measures about 4 inches. I may need to make it a bit bigger if I need better exposure. This allows me to make a bone cut here and remove the femoral head. We place a metal stem that fits into the femur, like this. We put a metal cup that fits into the pelvis. There's a plastic insert that fits into the cup, and a ball that fits on the end of the stem. And the hip replacement rotates like this, metal or ceramic against plastic. This is why the pain goes away, because there's no more bone grinding against bone. We use a computer-assisted navigation system to help restore your anatomy as accurately as possible. This is similar to a GPS system that one would use for direction, only this is for surgeons. We place 2 pins directly into the pelvis right here, and then attach ceramic balls to the end of these pins. The pins come out at the end of the procedure. These balls are read by a camera device that feeds into a computer. The computer then has me mark a couple landmarks on the bone here, which it records. Before we put in the real implants in place, we assemble what we call trial implants that look just like the real ones, but will give us a sense of how well we have restored your anatomy. The computer will tell us whether the leg is longer or shorter, wider or more narrow. The implant is modular and gives us considerable flexibility to change the length or width of the implant if needed. We then put in the real implants. It tends to be tremendously accurate and has been a great tool for us. I inject the hip with a long-acting pain medication at the end of the procedure. With the spinal, the soft tissue injection, and oral pain medication, we do a very good job of controlling your pain, but there's no way that we can completely eliminate the pain. We start with the very strongest pain medication that we can use, and then can modify the dose or drug as necessary. We have many options, and we'll work very hard to find the medication combination that works for you. It takes me about an hour to do this operation. We'll have you out of bed the day of surgery and up marching in place. The next day, you'll be walking the halls with a walker, and then the day after that going home, so typically 2 nights in the hospital. Patients that have a revision done may need an extra day in the hospital. By the time that you go home, you'll be independent enough that you can get in and out of bed by yourself, get to the toilet, and climb stairs. For those patients that have difficulty reaching that level of independence, a short nursing home stay may be recommended. For patients going home, we recommend that someone be with you around the clock for at least the first week. You'll notice at the extreme of any motion, the metal neck of the femoral implant will impinge against the plastic liner and lever it out of the socket. This is called a dislocation and obviously is a bad thing. You would have pain, not be able to walk, and need to call an ambulance to bring you to the emergency room for us to put it back into place. Fortunately, this is an extremely rare event. We have you avoid certain positions for the first 6 weeks to allow scar tissue to build up around the joint to help stabilize it and to minimize this from happening. Physical therapy will spend time going over these precautions with you, as well as giving you a stretching and strengthening program to work on at home for the first 6 weeks. We then have you go to physical therapy at the 6-week mark to work on what we call our Phase 2 exercise program with more advanced stretching and strengthening. We lift all but 2 of the restrictions at 6 weeks. 2 restrictions will remain forever. The most risky position is when you bend and twist. From a sitting position, anything between your legs or over your legs is fair game. You can bring your leg up, bend to the middle or over your leg. Once you get beyond your leg, this begins to become unsafe. If you were to bend and twist, such as this, the hip could dislocate out the back. From a standing position, the rule is the same. Anything in front of you or between your legs is okay. If you bend and twist, such as plugging in a vacuum cleaner or throwing wood, you can potentially dislocate out the back. As long as you keep things in front of you, it would be unlikely that you will ever have a problem. Driving is not advised for 4 to 6 weeks. For the right hip, you need to have enough strength that you can slam on the brakes and be safe. For the left hip as well as the right, you need to be off narcotic pain medication so that you're not driving under the influence. Risks, percentage-wise, are quite low, but if they occur, they can be pretty significant. Risk of infection is about 1 to 2% nationally. Our infection rate has always been less than that, and we range from 0 to 0.75% in a given year. We give antibiotics before and after the procedure. We use space suits with a hood so that our hair and skin do not flake off into the surgical field, and we have special airflow that blows air away from the patient, not directly on you. Wound healing can very rarely be a problem. Injury to nerves or blood vessels are very unlikely and are 0.58% and 0.1% respectively. Fracture is also very unlikely. Blood clots can develop in your legs, and if they travel to your lungs, can be serious. We put you on medication to minimize that risk. The medication can be a drug called Coumadin, Lovenox, or an adult full-strength aspirin, depending on your medical history and risk profile. In addition, the use of spinal anesthesia decreases this risk, as does the use of an inflatable device on your feet to push the blood back up through your veins, and the fact that we get you up and out of bed so quickly. The risk of blood clots without treatment can be as high as 47 to 64%. Even with treatment, the risk is about 6%. The real risk is that these clots move and go to your lungs, which can be life-threatening. This risk is less than 0.01%. The risk of bleeding complication from the Coumadin is 1.2%. Leg length can sometimes be an issue. We use the computer navigation device that I already described, so we are typically extremely good at getting your leg lengths exactly the same. But the longer that the operative leg is, the more stable and less likely to dislocate it will be. You would rather have a leg that's a bit longer and stable than a leg that's exactly the same length, but every time that you bend over, it dislocates. If I need to lengthen your leg, it's usually such a small amount that people can't really detect a difference. Rarely, I may need to lengthen the leg long enough that you can tell a difference. The worst scenario will be that we need to put a lift in the non-operative shoe. Again, this is an extremely rare event. We use the latest and the greatest implants, cement, and plastic inserts. I think that it's reasonable to expect 20 years out of this hip, but it may be less than that, particularly depending on your weight and your activity. The 20-year survivorship of total hips is about 85 to 90%, meaning that these implants are still in the patient and functioning at 20 years. I don't recommend that you run or jump with the new implants, but you can do pretty much anything else that you want within the dislocation precautions that I've mentioned. The more stress you put on the implant, the faster that it will wear out. Most patients do not lose enough blood that it becomes an issue. We used to have all of our patients donate their own blood before surgery, but they then start with a lower blood count and may be more likely to need blood. For most patients, we can use a drug called tranexamic acid, which significantly decreases blood loss. For high-risk patients, we can use a device that recycles whatever blood that you may lose over the first 24 hours. Whatever you lose during that period, we can then retransfuse to you. If you were to lose enough blood that you needed a transfusion, the blood bank blood is all screened for AIDS and hepatitis. The risk of disease transmission is exceptionally low, but not zero. The risk of AIDS is 1 in 200,000 to 1 in 800,000. The risk of hepatitis B is 1 in 200,000, and the risk of hepatitis C is 1 in 3 to 5,000. Finally, there is a mortality rate of about 0.07%. I have never lost anyone on the table in my career, and we certainly don't expect to start. For this reason, we have a family physician from Viroqua look after your heart and lungs and general health before we proceed with surgery. That person will then also look after you while you're in the hospital and follow you post-operatively. Other unexpected complications can occur that have not been listed. These would all be extremely rare and have a likelihood of less than 1%. So these are the main points that I like to discuss with my patients. I will return in a few minutes to make sure that I answer any questions that you may have. Thank you for listening.